This is Dr. Sergio Ruiz from Aguas Calientes, Mexico, which is in central Mexico, I understand.
Yes.
You've been a anterior segment surgeon there for 15 years after training in Mexico City.
Yes,
Yes.
that's right.
And today we wanted to talk to you a little bit about how you've seen phacoemulsification progress, the technology, where you see it's going.
Yes, I am very pleased to be here with you this morning. I've been into anterior segment and cataract surgery for the last 25 years, since I finished my residency in Mexico City. I have seen phacoemulsification start since the end of the extracapsular cataract. That was back in the 1990s, and it was a very superior surgery. I think phacoemulsification has improved with technology, with new surgical techniques, and new intraocular devices and instruments.
Can you tell us a little bit about how the instrumentation has changed over time?
Yes, I think instrumentation has been very special. Has a very special place in ophthalmology because we now have instruments that can make our work easier and to make a recovery of our patients faster. They can see better in a few days, some hours. So the instrument is it's a part of our practice, everyday practice.
Okay. I understand that you do a lot of pre-chopping. When did you start using that technique, and how has it improved your outcomes and surgery?
About 20 years ago, in one of the ASCRS meetings, I met Dr. Takayuki Akahoshi doing the pre-chopping. And I thought we didn't have any things about lasers back in those days.
Right.
But pre-chopping make cataract surgery easier, faster, and you can make more cases, operate on patients, more patients, and with the safe procedures, with the aid of little instruments called pre-chopper. I think it's back in 20 years ago, we only have the one pre-chopper from Makawashi. It was ASCRS, I think, his brand.
Right. So now are you using more than one type depending on the grade of cataract and so on? Or?
Fortunately, we have different types of pre-choppers. One can be the universal ones that you can use for kind of soft or medium cataracts, or the very hard cataract, you use the hard pre-chopper.
Right.
And I know there have been different choppers now, but once you understand the technique, you can use, like a universal chopper for universal cataracts.
Right. So you're mainly using one at this time, or you use a variety of them?
One at this time, but I have for the hard cataracts.
You have, okay, so you've got the one in case
I have used the Aguilars, and I have used the new one is the Vienna chopper. I haven't used it yet. I think it's a little wider plate, and has a little sharp edge in the point and one side, and it's going to make a difference for soft and medium cataract.
Okay. Would you say, you mentioned earlier that this allowed you to do more cases safely. How much would you say that it cuts down on the surgery time?
I would say that it will cut you, especially the ultrasound time, maybe like 50 or 60% the time of phaco ultrasound.
And does that shorten the entire length of time of surgery then?
Actually, the entire length of the surgery, because once you can emulsify the nucleus in a short time, you can do your INA, and then you can finish your surgery probably, like 20% less every case.
Okay. And how about complications such as corneal edema and things like that? Do you find that the chopping, has that reduced that over time for you?
Yeah, well, the corneal edema will have like a ultra, the things that damage the endothelium will be the ultrasound, the solutions that go into the eye,
Right.
and the maneuvers that you make with the instruments, and you don't touch anything inside the eye. I think it's once you have the right instruments and you have the right skills to use them, will be a chance to have less damage to the eye than regular ultrasound, and you do a sculpting, and that can damage you.
Okay. Now, I understand you use the Harmonix tip as well. What do you
Yeah.
find useful or helpful?
Once it's another instrument that came from Kahoshi's is the Harmonix tip. We have. I started with the Kelman tip for many years. I think the Kelman tip has had some modifications, but it's still very small. And now the Harmonix came out with a wider mouth. They can get a cataract emulsified fragments in a shorter time, and that means less ultrasound.
Okay. All right. So you're working on some instruments now with ASCRS, is that correct?
Once you start doing cataracts, then you have some chances to see how can I do this better with a different instrument. And sometimes cataracts are hard. This is going to be for a hard cataract that I'm going to call it like a micro finger with sharp edge. So we can kind of do a contour pre-chopping, and it's just an instrument that holds a cataract and will help you cut it in the counter pressure. It gives you a little, like maybe a better chance to cut the hard cataracts.
Okay. So this would be in place of the ball type retainer that you're using?
The nucleus sustainer,
Yeah.
regular nucleus sustainer, make it a little wider so you can have two plates inside. One of has a sharp, little finger type. You can split it.
Okay, so it has both of those in the instrument.
Not in the same, it can be by manual.
Okay, all right. So you're holding it with the sharp finger, and then you're using the chopper on the other. Okay, so what was the issue what was the challenge that caused you to want to design this new instrument?
The challenge was that once I had the re-chopper here, I needed to sustain the nucleus.
Right.
But the sustainer didn't have any sharp edge.
Right, so it's not really holding on, you kind of have to...
It holds, but it doesn't cut.
Doesn't cut. Okay, so you're actually now both holding and cutting with it as you're chopping.
It's kind of modification of different surgeons from one from Brazil that I've been watching them, Oshi, Roberto, Pilar, and it's nice to visit and see your friends again and see how they're doing, what different instruments that we have this year, what things we can improve.
So where is this in development? Have you tested prototypes or are using it regularly?
Still designing, right?
Okay.
Making drawings and see how can it.
Okay. So you're talking here with the people at ASCRS about that as well, too. Okay. You talk here a lot about hard cataracts. How big of an issue is that in your part of the world?
We have quite a big issue in Mexico. We know that some people don't have access to ophthalmologists. It takes a little time to go to a place where they have trained ophthalmology centers. So we have probably 20-25% of very hard cataracts.
So that's a pretty high proportion of them. Yeah.
And, for a regular cataract surgeon, that will give you a little hard time to deal with hard cataracts.
Now, are you using lasers at all in cataract surgery?
No, not yet. I've been using for like in these meetings, but I think the cost-effective issue in cataract has given me a chance to have instruments and to do a good job and not being able to put laser into my practice yet.
Right, right.
I think it's an excellent laser, and it helps you to make a good capsulorhexis and incisions. But I think so far the cost effective is not on the laser side.
Right. Hasn't really been shown to be any better, in at least that I'm aware of. But,
not so far, but I think it's the future will tell. Maybe
Right.
we could have different lasers, or maybe a little things that can dissolve the cataract, so you can just aspirate and come.
are you involved in training residents? Or?
And not yet, not now. I was in a residency training program for 20 years.
Okay.
But now I'm in my private practice.
Right. Okay. Okay. So how do you? What is the role of increasing efficiency in meeting the need that you're seeing? You're seeing more people who need cataract surgery, a lot of advanced surgeries. How important is it to be able to practice efficiently to meet that growing need?
Well, I think it's the importance is that you can deliver the best care to your patients and to see if they have a different techniques or different instruments that appear every year, and so they can help you into your regular practice, and that will you can give your patients the best care, and they can have the best recovery, faster.
Are you seeing your levels of complications going down over time? Your visual outcomes improving over time?
Actually, the problem is that your complication go down, but then the time goes up, and so somebody's going to win. The time's going to win, obviously.
Right.
So but this is very nice to be here in this ophthalmology meeting, and being an ophthalmologist has been a great choice.
Okay. Where are you are you with a hospital now, or are you just in your own clinic,
I'm
or
in a
what?
private practice, but I'm in a hospital in my hometown. This is like a 1 million people city.
Oh, okay.
And we have a busy practice.
Right. Do you do many premium lenses, or are you mostly doing monofocals?
We're doing it 20% premium lenses. I think they're catching up, but the price is one of the main issues. And one is trying to convince the patients that what is going to be the best for them.
Right. Do you do many toric lenses?
Toric will be 15%.
Okay.
And then multifocal will be 10%.
Okay. How do you handle astigmatism, or what level of astigmatism do you use a toric?
We try to correct astigmatism if the patient is complaining of using some glasses after surgery. We offer a chance to reduce their independence of glasses using an intraocular lens with a toric component. So I try to see the patient needs and see if they understand what's happening, because I think it's a customized IOL has to be according to what the patient needs.
Right. So you don't have a set level of astigmatism that you would use when you're looking more at what the patient
You can be like a 1.5 or 1, but it's sometimes like the patient is very comfortable using glasses with a 1 diopter of astigmatism.
And
if you use this 1 diopter.
what kind of instruments are you using to mark and make sure that you've got your
Your astigmatism axis. Well,
Right.
so far we're using the slit lamp marking with the astigmometer, using preoperatively and transoperatively.
you getting pretty good results with
So
that?
far, yeah. I know that they have a very nice astigmatism marker, but I've used it quite a few times, but mostly I use the slit lamp.
Okay. What else would you like to talk about? What have we not talked about that you'd like to discuss?
Well, I just would like to see new instruments every time that make surgery easier, safer, and hopefully cheaper.
Right, cheaper. All right. Well, thank you very much for coming, Dr. Ruiz,
You're welcome.
and good luck with your work.
Thank you very much.